Good morning, good afternoon, everyone. My name is Mugdha Thakur, and I will be presenting some work that I have been doing with the Biocomplexity Institute at University of Virginia. I'll be talking about cost-benefit analysis on different intervention strategies to prevent post-COVID-19 measles resurgence. Let's see. So a quick background on why we started doing this project is there had been a lot of news. So lockdowns happened, and maybe due to healthcare access prevention or just the fact that it was lockdowns, the childhood MMR rate, like all other childhood immunizations, had declined a lot. And there had been talk about how that will impact once the social activities resume, or just when, even if not to the original state, even some more. Now, I really like this video of like GIF that was published in The Guardian in 2015, where it shows that how, as you increase the vaccination rate, like you really need a very high vaccination rate for measles to not break out upon any importation. So I'll quickly do a shout out to the related work that was really important in inspiring the different modeling assumptions and the different parameter assumptions that went into this modeling study. And also in inspiring on the counterfactual or the scenario thinking. So jumping right in, two things that we have really tried to quantify and analyze is one, what is the probability of large measles outbreak post-lockdown? So what is different? There is definitely vaccination rate has gone down, and that's the basic assumption. But then also we look at this probability in these different scenarios of what if the transmission rate is any different due to the changes in social behavior, or even if we try to include different interventions like homestay due to isolation or quarantine, then how much it can impact in different post-lockdown immunization scenarios. Now, the second part on it would be doing some cost-benefit analysis. And then that is also done in the context of these three different variables that we are going to focus on. When we go to the methods, I'll talk about, there are four different types of methods. One would be building an immunization model. So, well, let me step back. So this is an agent-based model done on a realistic but synthetic population contact network for Virginia as a case study. And so each node will represent a person, and then different activities, survey and census information all went into making this network, which then what we do is first step would be immunization model. So assigning for each node, assigning if the person was vaccinated or not in the duration of simulation. Then there's disease model, where we go into more details, but we do a 365-day run of if there is single importation of a case, how it will spread. Then as part of interventions, we have stay-home interventions for isolation for symptomatic diagnosed individuals, and then quarantine for household contacts of the isolating individual. And then lastly, for the cost-benefit analysis, I'll talk about how what different costs we calculated, and then what would be the benefit calculations. So in immunization status assignment, the baseline would be pre-lockdown. And for that, for children, what we used is we have school-wise MMR rate obtained from the Virginia School Immunization Survey. And in that, the reporting goes for a kindergarten rate and the 6th grade rate. So we did age-based assignment of vaccination status based on preserving the immunization rate in the in the neighborhood or the school district kind of a situation. Then for adults, the data is not nearly as detailed. So what we did is through National Immunization Survey or the ChildVax View that CDC has as an interactive tool, what we could do is we picked the numbers for the state of Virginia from 1995 to 2004, which means as of 2022, all the people from that survey are definitely going to be adults. Then, and then we did a weighted average over the years and assigned it as a uniform random assignment throughout the network of adults. Let's see. Okay, so quick mention. So in the post-lockdown, what we're doing then is that we do scenarios of 5%, 15%, 25% reduction in childhood immunization. In that reduction will be uniform randomly. Now, in the disease flow, what we do is at the initialization, each node based on the age and vaccination status, they will start as a susceptible or a vaccinated individual. Now, we're assuming vaccination is perfect, so there's no propagation of disease into the vaccinated class. For the susceptible, we introduce one infected node from in the age group of 5 to 17. And then we initialize the agent-based transmission where the infected can then transmit to susceptible, and they follow the compartmental state transition things. And anytime a node is infected, there is a compliance rate by which that infected person around 3 to 4 days of being infected. So that's when the measles rash comes in, and that's when we set a compliance rate, and that node can isolate. And for quarantine, then we look at the nodes that are household contacts of the isolating individual. Let's see, and then lastly, the transmission would be an artifact of the transmission rate, which is a parameter constant. Then the time or frequency of contact of individuals, infected and susceptible individuals, and the duration of contact, which comes from the contact network that was built. Then again, looking into details of intervention model, like I said, whenever node U enters the infected state, then with some delay, there is a compliance rate with which they will either isolate or not. And then we look at the isolating individual's household contact, and they have a similar compliance rate for each individual if they will stay home or not. Now, when I say stay home, the way it is incorporated in the model is we have all the edges of the staying home nodes that are not household contacts will be removed or reduced in weight so much that the total product of transmission goes to 0, and that's how they will be isolating in the literal sense. So to summarize, we have a social contact network that comes from different sources of census and activity data and immunization data. Then we set a contagion process on it by which the disease progression happens. Throughout the disease progression, the interventions are applied, which manipulate the network for the given number of days based on the intervention. And then we do the cycle for 365 days per scenario. And let's see. So that was about the disease disease simulation. The next step would be cost model. So this is, so we are looking at total societal costs, and a lot of the assumptions are inspired from the Pike et al. Paper from 2021. So productivity losses would be calculated as look at the household income and the number of workers, so per capita income, times if, so what are the daily wages lost in the sense of the person who is isolating, and then for minors, what we are looking at, or children less than age of 15, is if they're isolating, i.e. they are infected, and that's why they'll need a caretaker whose productivity losses we calculate, or if it's simply any nodes younger than 9 years of age are quarantining, or if the household members are quarantining, any node that is younger than 9 years of age will need a caretaker, just in terms of a babysitter and their, or not babysitter, but a household member who's staying home to accompany the child. And that's how the productivity losses are calculated. The second would be the MMR doses. So again, we're looking at the overall societal cost. So each pre and post lockdown scenario has a level of vaccination rate. So what we do is we look at 228 is the cost for 2 MMR doses if individuals are vaccinated at the initialization of the experiment, then we calculate the total cost by multiplication. The last would be the direct medical costs, and that could be either hospitalization or outpatient, and that is that will be the total direct medical cost would be dependent on the incidence that we accrue from the 365-day simulation, where the costs are again calculated based on how many individuals will need to be hospitalized versus just need some outpatient kind of treatment. And these numbers come from a study which looked at the reported CDC numbers historically. Finally, just a brief peek into how the cost versus benefit will be calculated. Cost would be, again, in addition of the 3 components, in benefit, we are looking at incidents averted. Now, I have included the different factors that are going to affect each of these components, and we'll see how they actually play out in the results once we get there. All right, so first things first, the first problem was we wanted to see what is the resurgence probability in the post-lockdown scenario, and we have compared 2 different scenarios. One would be if the reduction in vaccination was uniform, so just uniform randomly, or weighted by the household income. So lower income nodes would be more prone to missing the vaccination and thereby affecting the overall distribution on the network. And what we notice is that around 10 to 15 is where we can see the threshold, in the sense that it really, beyond that level of decline in immunization rate, the probability of outbreak really kicks off very fast. Then, so we, this is, this BMC paper just got online yesterday. So if anybody's interested, I can leave this link in the chat after a presentation. But if you're interested, we have a little more detailed scenario comparisons. We look at vulnerable community when in the different decline situations. And then we also see the importation effects, whether the seeding was in the urban region or a rural region. For the scope of this presentation, I really want to talk about the cost analysis. And so that's why I'll skip over those results for now. So let's see, the first one would be, I'll talk about what the different axes are first. So on the x-axis, we have total incidence for each of the different scenarios, and the y-axis would be total cost in terms of in million US dollars. We do see that when alpha is really high, so this is when extremely low immunization scenarios, the ranges are crazy. And what I would like to show is what's going on in here. So what we can see is that the squares, which correspond to like a really high compliance to stay-home interventions, is always going to be cheaper and more cost-effective. And this is when the transmission rate is preserved in the pre and post-lockdown scenarios. Then the second part would be looking at, so if we noticed that 95% compliance was great. So what we're seeing here is that if the compliance was as high as it can get, then how does the transmission rate, which can affect, and what we see is that the effect of tau really increases, or it becomes really critical as the alpha gets higher. So in lower immunization rates, it's the effect of tau really shows in, and that's because tau is impacting threefold. So if I go back to this model, we can see that tau is affecting incidence, and then tau then through incidence affects like 2 components of the cost. Next, so if I then look at more benefit versus cost comparisons, on the x-axis we have incidence averted. So how much more, so it will be incidence in the baseline minus incidence in the different scenarios. Baseline is again transmission rate calibrated to the New York City outbreak in 2019. And then we also have different compliance level in the base case and immunization, 0 immunization decline. Y-axis is the incremental cost. Again, what is the extra cost that comes in different scenarios. And then each of these panels represent different alpha, which is, so this is 5% decline in the post-lockdown, 15 and 25 in the childhood immunization rate. Let's see. Then we have, so the first part, we can see that incidence averted. So we will actually avert some more extra incidence only when the transmission rate is reduced. And that tau constitutes any reduction in transmission due to interventions apart from, or not isolation. So generally speaking, if you're more careful and or preventative behaviors. The second case would be if we look at, so here I'm focusing on only the green dots or different markers. And what we see is that in base case, so if tau is fixed to 0.5, which is similar to the calibrated for the New York City outbreak, what we can see is highest or most aggressive homestay interventions will be both cost saving and will have the highest or lowest incidence between especially for 5, but you can also see in the 15 and 25 where the square greens would be closer to the origin. Or I guess closer to the y-axis is what we're looking for. Then in terms of when we look at different alphas, so as you get to the lowest or highest decline, lowest immunization scenario, the incidence effects of homestay interventions, and then tau, which will be daily interactions, that really, the interplay really kicks in, whereas in lower alpha, we had somewhat of clear clusters based on the colors that are going on there. So to conclude, first would be a 15% or higher drop in MMR vaccination rate will is really prone to large measles outbreak upon importation. In absence of other interventions, so let's say there's no changes in tau or transmission rate, then more aggressive stay-home implementation is the most cost-effective. And finally, as the immunization rate declines, so as alpha gets higher, controlling transmission rate also becomes more critical, because then each additional effort in reducing transmission resulted in a much higher benefit. Right, some of the limitations would be, we assume that the vaccine is perfect, like I mentioned, but for the scope of the study, I haven't really seen any proofs or published literature which talks about the secondary attack rate of modified measles. And that's why we think that, at least for this 1-year simulation, that is a reasonable assumption. Then there is some lack of clear reporting for current adult immunization rate estimates. So that can definitely change the spread of the outbreak. Then activity travel patterns. So in itself, in the synthetic contact network that we're looking, we haven't really changed anything in pre to post. So all of the differences that we see are an artifact of varying VHI and tau. Then lastly, what I call outbreak size would strictly mean cumulative incidence over the year. So even if the outbreak is not over for that instance, we still only measure the cumulative incidence until the end of the experiment. Now, parts of this analysis are still ongoing, so we definitely have plans on including some demography, or at least looking at some demography related effects. Then there is contact tracing is very critical in a control of an MMR outbreak when it happens. So some of the future directions for us would be to look at that, and then to really analyze this outbreak effect. We also would like to do some longer horizon experiments where we actually know the outbreak size, and then looking into modified measles case, and also instead of looking at a fixed pool of nodes, if we have a dynamic network, how that will change things. So yeah, finally, I'd like to acknowledge all the funding grants and all of my collaborators for sure. And the BI members, they've always been really good critical effort. I would really like to thank all of the attendees right now, and especially Stephanie. I know we've made your life hard by changing admin levels things. So thank you so much for being patient with us. And yeah, thank you all. I will take any questions. I'm leaving this email up. I have also included my collaborator's email along with mine, just because she is still at UVA, and she will be more actively checking her emails than I do for that one. But yeah, and like I mentioned, this is an ongoing study, so any input, feedback will be really great, and I look forward to the discussion we can have.
Thank you so much, Mugdha. Thanks for all your impressive work. So now, yes, we have some applause from the audience, and if anybody would like to ask questions, feel free to use the chat, or you can also raise your hand and ask questions directly to Mugdha. Just wait a minute or two. We have a few minutes remaining for some questions. If anybody has anything. I see Chaylin has put something into the chat. Mugdha, can you see her question?
I can see. Okay. So Productivity losses. So I'll go back to that slide. We do consider the productivity losses of the caretakers. And yeah, I'm sorry for the fuzzy text here, but yeah. So in terms of caretakers, we look at the productivity losses for caretakers only when the isolating individual is less than 15 years old. And then for quarantine individual, we calculate productivity losses for caretakers for 9 years and younger. Notes.
Thanks, Chaylin. Thanks, Mugdha. We have maybe time for one more question. And if not, oh, yep, there's one more question from Chaylin.
So to get these assumptions, they're primarily inspired by the publication by Pike et al., where so they we would in the future directions like to incorporate in case of like look at really severity of the disease and then have caretakers a little more heterogeneous based on the severity of disease. But for these assumptions, they come from Pike et al. And then also from the Virginia directions in terms of what is this cutoff of children who need to be accompanied and can't stay home by themselves.
Great, thank you.